Hello, today's discussion will be in the topic Meconium Aspiration Syndrome. This is a serious respiratory condition seen in newborns where the baby aspirates the mixture of meconium and amniotic fluid into the lungs around the time of delivery, and meconium is the first stool passed by the baby. So in today's class, we will see the definition, risk factors, classification of Meconium Aspiration Syndrome, composition of meconium, followed by pathogenesis, clinical features, diagnosis, treatment and outcome of this condition. Incidence of Meconium Aspiration Syndrome: 75 to 90% newborns, they pass meconium within 24 hours after birth, and 10 to 15% deliveries are delivered with meconium stained amniotic fluid. So out of this, 3 to 5% develop Meconium Aspiration Syndrome. So that means 3 to 5% will aspirate the meconium. And if they develop Meconium Aspiration Syndrome, 50% of these babies require CPAP or mechanical ventilation. CPAP is continuous positive airway pressure, and mechanical ventilation, that means the respiratory support is required in 50% of the cases. And mortality is also quite high. In the severe cases, it is 3 to 5%. Now come to definition of Meconium Aspiration Syndrome. It is a respiratory disorder caused by aspiration of meconium fluid which is contaminated with meconium, that is baby's first stool, and that goes into the tracheobronchial tree which presents with the characteristic radiological findings. So if all these criteria are there, so this is known as Meconium Aspiration Syndrome. And aspiration occurs either in utero or more commonly with the first breath after delivery. The meconium is aspirated. The term meconium is derived from the Greek word which means arion, that means opium-like. Characteristics of meconium is the first few days stool of the baby is known as meconium. The characteristic is it is sterile. The viscosity of meconium is thick, viscous consistency it has. Color is black, green and odorless. There is no smell. And the pH of this is 5.5 to 7. It results from accumulation of debris in fetal intestine during 3rd month of gestation. So let's see what are the contents of the meconium. It comprises of water maximum 72 to 80% is water. So in that there is gastrointestinal mucin, lanugo hair, fatty material from the vernix gaseosa, amniotic fluid, porphyrins, interleukin 8, intestinal secretion, blood group specific glycoproteins, bile pigments, pancreatic enzymes, phospholipase A2 and gastrointestinal desquamated cells. Those are the epithelial cells. So all these composition is present in the meconium. Now come to the consistency. The description is meconium is based on the consistency. It is described as watery when the amniotic fluid is thinly stained, like in number 1. And then moderately stained meconium, that is the picture seen in number 2. This is an opaque fluid without particles. And then number 3, which is thick meconium, so is known as, it is pea soup like fluid which is thick, containing the thick particles of the meconium, so known as thick meconium. So these are the 3 types of consistency seen in the meconium. And the presence of meconium in amniotic fluid is essential for diagnosing a case as meconium aspiration syndrome. Now see the Wiswell classification of meconium aspiration syndrome. This shows the severity of the disease. The severity can be mild meconium aspiration syndrome when cases of this meconium aspiration syndrome is requiring less than 40% of oxygen for less than 48 hours. It is moderate meconium aspiration syndrome when the cases require more than 40% of oxygen for more than 48 hours. And it is classified as severe when cases are requiring assisted mechanical ventilation, either CPAP or the mechanical ventilation for more than 48 hours, and this is often associated with persistent pulmonary hypertension. Now, what are the risk factors for meconium aspiration amniotic fluid which may land up to meconium aspiration syndrome? The risk factors are divided as maternal factors and fetal factors. So let's see the maternal factors first. So number 1, gestational diabetes or hypertension in the mother. If the mother is a smoker, if there is eclampsia in the mother, oligohydramnios is present, if there is chronic respiratory or CVS diseases in the mother, if there is a placental insufficiency, chorioamnionitis, and number 8, maternal drug abuse are the risk factors. Coming to the fetal factors, if the fetus is term, post-term or post-dated baby, small for gestation age baby, those are the intrauterine growth restricted babies, abnormal fetal heart rate, and number 4, fetal gasping secondary to hypoxia will be the risk factors in the fetus. Now let's see the physiology of meconium passes. Why and how it is passed. Meconium is first found in the fetal ileum between 10 to 16 weeks of gestation in the uterus. Under normal circumstances in utero, there is no passage of meconium. Passage of meconium is very uncommon because the baby should be passing stool after birth. So under the normal circumstances, they do not pass meconium. The reasons are, number 1, there is lack of strong peristalsis in the newborn because there is low level of motilins. Number 2, there is a good anal sphincter tone in the newborn, so it is controlled and then do not pass the meconium. Number 3, cap of viscous meconium in the rectum is acting as a barrier and then meconium is not passed. But if there is any disruption in these mechanisms, then the baby can pass meconium in utero and then there is increased risk of aspiration during the delivery. Okay, so mechanism, how in utero meconium is passed. So these are the reasons and the mechanism of a baby passing meconium in the utero. So if there is a fetal distress due to intrauterine stress like hypoxia, acidosis or infections, then these factors will lead to relaxation of the anal sphincter, so there is in utero passage of meconium. So another one can be by head or cord compression. So babies during delivery, there is head or cord compression and this leads to vagal stimulation. So whenever there is a vagal stimulation, that leads to relaxation of the anal sphincter and ultimately leading to in utero passage of meconium. And in cases of post-term babies or post-dated babies, there is maturity in the GI tract, so motilin release will be in excess amount, which promotes the GI peristalsis, ultimately stimulating the release of meconium. And there is better myelination in the full term or post term babies. So if the myelination of the nerve fibers are better, there is increase in the parasympathetic tone, which ultimately leads to relaxation of the anal sphincter, so release of in utero meconium is there. And then ultimately gasping can occur before or during delivery, leading to aspiration of the meconium. After the release, by these three factors, meconium is released in utero. So after the release of the meconium, while delivery or in the uterus, the baby may gasp. So with the gasping, aspiration occurs. Now come to pathophysiology. What all can happen after aspiration of this meconium? So number one, if you see meconium, it causes peripheral airway obstruction. This obstruction, if it is complete, it leads to atelectasis, that is collapse of the lung, which means mismatch perfusion. And if the obstruction is partial, it leads to ball-valve effect. That means it is creating one-way passage. That means air goes in but cannot be exhaled out. So there is air trap. So air trapping leads to distension of all the alveoli. When the distension is too much, then there is air leak. Bursting of the alveoli leading to air leaks, ultimately leading to pneumothorax or pneumomediastinum. So pneumothorax, if it occurs, then there might be acidosis, hypoxemia and hypercapnia due to decreased lung compliance. And another, the meconium aspiration can cause proximal obstructions. So whenever there is a proximal obstruction, the lung compliance decreases. So there is acidosis, hypoxemia and hypercapnia. Next, there can be inflammatory or chemical pneumonitis due to the meconium. Meconium itself is an irritant material. So there might be just a chemical pneumonitis. If an inflammatory process occurs, then there might be pneumonia also. So this will lead to acidosis, hypoxemia and hypercapnia. And another meconium, it leads to inactivation of surfactant. So there is surfactant dysfunction, ultimately leading to acidosis, hypoxemia and hypercapnia. So these three factors will be leading to shunting of opening the right to left shunt. So whenever there is a right to left shunt, pulmonary flow increases and there is high chance of development of persistent pulmonary hypertension. So this is a total pathophysiology occurring in meconium aspiration syndrome. So according to this, we will be getting different clinical features. Now come to diagnosis, how you are going to diagnose meconium aspiration syndrome. First is you have to always take a history like any other case. So in the history, you will see the amniotic fluid is meconium stained. So there is a history of meconium stained amniotic fluid. That is the main clue. After that, the baby might be term or post-term or intrauterine growth restricted baby. So there is a high chance, this is a very high risk factor in the baby. So this is usually found. And another is baby, many babies, they are depressed at birth because of hypoxia and aspiration. Then come to physical examination. So you see in the picture, the baby is all meconium stained. So in the physical examination, there is evidence of post-maturity with the peeling of skin, long fingernails and decreased vernix caseosa. And then there might be umbilical cord, hard palate or nail, all are stained with meconium. And then meconium is found, if it is found below the vocal cord, this is definite, this child has meconium aspiration syndrome. Then clinical features which is present at birth, the baby starts developing respiratory distress once the meconium is aspirated. Initially there is a apnea, this is followed by respiratory distress, and respiratory distress starts within 1 hour of life and the baby deteriorates in next 24 to 48 hours. If untreated, this progresses to respiratory failure and then ultimately, if it is very severe, mortality might occur. And then sometimes the severe condition usually subsides by 72 hours. So in the picture, if you see, this is a intrauterine growth restricted baby who is very long and thin. And then detail, if you see, the nail might be stained with the meconium, skin is stained, and then umbilical stump may also be stained with the meconium. Now come to the signs of respiratory distress, which is seen. There is flaring of Allanese, small wave of obstruction is there that leads to tachypnea, cyanosis, grunting, intercostal retractions. Partial obstruction of airway may lead to air leak syndrome, that is pneumothorax and pneumomediastinum. The chest is barrel shaped, that is due to over distension of the alveoli because of the air trapping. And if you auscultate the lungs, you will get rales and rhonchi. Tachypnea may persist for many days, sometimes even for several weeks, and the child may become oxygen dependent for a long period in a meconium aspiration syndrome child. Other system which are getting affected is central nervous system, where you might get signs of cerebral irritation, hypoxia. So there might be jitteriness, seizures, and sometimes even coma. And abdomen is pushed down, liver and spleen is also pushed down because of the hyperinflated lungs. Now come to the differential diagnosis. This picture you can see the umbilical stump being meconium stent. The differential diagnosis will be congenital pneumonia, respiratory distress syndrome, that is a hyaline membrane disease, congenital diaphragmatic hernia, transient tachypnea of the newborn, and even congenital heart disease with a heart failure. All are different causes of respiratory distress which may be a differential diagnosis for meconium aspiration syndrome. Now come to investigation to diagnose. In the investigations, you do blood gas analysis, ABG, arterial blood gas analysis, which may show hypoxemia, metabolic acidosis, or hyperkarybia, respiratory acidosis. And serum electrolyte disbalance can be there, so you look for sodium, potassium, calcium at 24 hours. And then do the complete blood count, and then many times septic screening is also required because there is high chance of sepsis. X-ray findings. In the X-ray, you might get bilateral patchy opacities or coarse infiltrates, increased AP diameter because of hyperinflation, flattening of the diaphragm because of hyperinflation, and there might be air leaks in 10 to 30%. So you might get features of pneumothorax or pneumomediastinum, and many times you can see atelectasis, that is a collapsed lung if there is a complete obstruction of the bronchus. And this radiographic changes gradually resolves within 7 to 10 days, but sometimes it may persist for several weeks. Two-dimension echocardiogram can be done to evaluate the severity of pulmonary hypertension because of the right to left shunting. Now come to management. So management during delivery, how you should be doing. If the infant is not vigorous at birth, that means not crying, then initial step should be under red and warmer. Very quickly you clear the airway as early as possible, give free flow oxygen, and do a direct laryngoscopy with a suction of the mouth and hypopharynx, followed by intubate the baby and then suction directly to the ET tube. And here drying and stimulation is delayed. So before drying stimulation, you should be doing this action if the baby is not vigorous, not crying. If the baby is apparently well and crying, then they do not require any intervention. Just monitor the baby closely for the development of respiratory distress. If the baby develops respiratory distress, then there might be chance of meconium aspiration. Most infants who develop symptoms will do so within the first 12 hours of life. So never bag a baby who is born with the meconium stent, or if the baby has a meconium stent liquor, before clearing the suctioning the mouth. Because if you bag, if the baby has aspirated meconium, when you give a bag and mask ventilation, it will be pushing the meconium further down, and the baby will the respiratory distress of the baby will increase further. So you should not do bag and mask ventilation in these babies. And postnatal management, then transfer the newborn to NICU, that is the intensive care unit, then monitor closely give respiratory support, and then sepsis workup should be done, and if required antibiotic should be started. So how you should manage respiratory distress? So in this picture you can see a baby on a CPAP. So because usually they require the respiratory support in the form of CPAP or mechanical ventilation. So oxygen via hood box, or you may have to start CPAP. If not improving, you go with the mechanical ventilation. High frequency ventilator might be required. Then ultimately, if not improving, inhaled nitric oxide. If not improving, ECMO is the another option, and in some centers they even use surfactant. 1/3 of the babies with Meconium aspiration syndrome, they require intubation and mechanical ventilation. So who are the babies who require mechanical ventilations? The indications. Okay, so number 1 is high oxygen requirement. If the requirement of oxygen is more than, if the FiO2 is required in amount more than 0.8. Number 2, if there is a respiratory acidosis with arterial pH persistently less than 7.25. Number 3, if there is a pulmonary hypertension. Number 4, circulatory compromise with poor systemic blood pressure and perfusion. Then these babies you start mechanical ventilation. If not improving, we go with the inhaled nitric oxide. So nitric oxide is a selective pulmonary vasodilator. It dilates the blood vessels in well ventilated areas of the lungs. And this is an ideal treatment for persistent pulmonary hypertension. So despite ventilatory maneuvers, if the child is not improving, if the child's persistent pulmonary hypertension is not improving, best treatment, ideal treatment will be inhaled nitric oxide. And this decreases the ventilation perfusion mismatch and improves the oxygenation in the infant with the persistent pulmonary hypertension. And then if those measures are not helping, then you go with the ECMO. ECMO is a machine which is similar to heart-lung bypass machine used in open heart surgery. So it pumps and oxygenates the patient's blood outside the body and then allowing the heart and lungs to rest. So ECMO, so that means extracorporeal membranous oxygenation. This is used for infants with refractory respiratory failure and who's having intractable hypoxemia. 40% of the MAS are treated with the inhaled nitric oxide, and if they fail to respond to nitric oxide, they require ECMO. So 40% of babies who are having treated with the inhaled nitric oxide fail to respond and they require mechanical this ECMO treatment. Survival rate with this ECMO is 93 to 100%. So whenever indicated, it is always best to go with ECMO as the survival rate is very good. Then role of antibiotics. This is indicated if infiltrates are seen in the X-ray or there are signs of pneumonia, and broad spectrum antibiotic can be used like ceftriaxone, amikacin or the aminoglycoside group. And corticosteroid is not routinely used. Reduce the meconium induced, it might reduce the meconium induced inflammation and prostaglandin mediated pulmonary vasoconstriction routinely, but routinely it is not used. Now come to supportive management. Supportive management, here you stabilize the hypothermia, hypoglycemia, anemia, correct the metabolic acidosis. Hemodynamic support is important, that is with the IV fluid. IV fluid we restrict 2/3 of the maintenance to prevent the SIADH and pulmonary edema. And then adequate nutrition, and then if required you can start with the inotropes. And if there is electrolyte disbalance, you correct those. Now come to the outcome or the complications of the severe Meconium aspiration syndrome. Ehrlich syndrome pneumothorax pneumomedastinum can occur in 15 to 33%. Persistent pulmonary hypertension occurs in 1/3 of the cases. 40% have abnormal pulmonary function test. Mortality is due to persistent pulmonary hypertension and air leaks, can be as less as 5% and it may go as high as 35% also. 3 to 5% is the normal scenario, but it may go as high as this if it is too severe. And there are some long-term complications or long-term outcomes. There is high incidence of long-term pulmonary sequelae, like requiring supplemental oxygen for around 1 month age, that is in 5% cases. 40% airway reactivity can occur, and there is a high incidence of development of asthma, pneumonia and abnormal pulmonary function in these babies. And pulmonary interstitial emphysema can occur, and many babies, because of the early hypoxia, there is damage to the central nervous system, so babies may be mentally retarded, may develop cerebral palsy, or may develop seizures like with a secondary epilepsy. So those are the long-term outcomes in a case, very severe cases of meconium aspiration syndrome. Now come to prevention. Monitoring during pregnancy is very important. Try to maintain the uteroplacental insufficiency and just monitor all the risk factors, maternal as well as the fetal risk factors you have to take care. And then continuous or periodic intrapartum fetal heart rate monitoring in high risk pregnancies is important. And time of delivery, induce as early as 41 weeks. Don't stay till for postpartum date, or don't delay the delivery beyond 41 weeks. Thank you. Next class I'll come up with another neonatal lecture.